So this is the talk that I'm going to give basically in the Benatine campus on October 31st for the neuroscience round. So if you see this talk, you don't have to come to Benatine to see the same talk. So the title is what can we do with PET, and I'm going to probably focus on Parkinson's disease because that's what I've been doing. And so the actual title would be what I've been doing with PET so far with the patient with Parkinson's disease. So in the first half of the talk, I'm going to talk about some dopamine imaging because dopamine is the key neurotransmitter that is impaired in the patient with Parkinson's disease. In the second half of the talk, I'm going to talk about pattern analysis with whole brain FDG-PET. So first, I'm going to introduce some different tracers that we can use to monitor different levels of a dopamine system. So before we go on, so Parkinson's disease is a neurodegenerative movement disorder that is characterized by this dopaminergic cell degeneration in the substantia nigra in the brain. So the number of patients is estimated about 100,000, and it's increasing very rapidly in Canada. This 100,000 is only Canadians. And the dopamine, in the initial stage of the disease, dopamine replacement therapy works very well because the dopaminergic cells are degenerated. So if you just give the dopamine precursors such as levodopa, it basically ameliorate the symptoms. And this is the early stage. Later on, they develop some side effects and so on. So dopamine is basically the key neurotransmitter in the Parkinson's disease. So this is a synapse, and everybody knows about what the synapse is. Okay, so anybody who doesn't know about what the synapse is? Yeah, synapse is basically, neuron is the cells of the brain, right? Neurons communicate with each other in the brain to transfer the signals. And synapse is basically where those neurons meet. So through the synapse, you basically transfer your information. And this is dopaminergic cells. So this this synapse, dopamine is released in this is a synapse. Right? So this is what happens in these dopaminergic cells. Dopaminergic neurons, tyrosine is converted to levodopa. Levodopa is converted to dopamine. Dopamine is now collected in the synaptic vesicles through vascular monoamine transporters. And this collected dopamine is released in the synapse. This dopamine binds to the dopamine receptors in the next neuron, which is postsynaptic neurons. And then once they do their job, they are taken back by the dopamine transporter as a recycling procedure. So if you inject radio-labeled radioactive dopa, F-dopa, you can quantify the activity of this DDC, which converts the levodopa to dopamine. So for example, the patient with Parkinson's disease, their dopaminergic cells are basically degenerated. When they have Parkinson's disease, 80% of the cells are dead, basically. So if you inject the dopa and quantify the remaining disease activities, you can see in the patient with Parkinson's disease, the activities are very low compared to the normal controls. So this decreased F-dopa uptake can be used as a biomarker for Parkinson's disease, as a probe of the dopaminergic cell degeneration in the patient with Parkinson's disease. And for example, if you inject tetrabenazine, which binds to the vascular monoamine transporter, basically the same story. Because these cells, these dopaminergic cells, are degenerated in patient with Parkinson's disease, so you have lesser binding in these regions that has a dopaminergic in the patient brain. this is Parkinson's disease, this is normal controls. So you can see that there's a huge decrease of tetrabenazine binding. And if you inject methylphenidate or FDG-PET, which binds to the dopamine transporter, same story. Dopaminergic cells are dead, so there's no place to bind. So the binding potential of the dopamine FDG-PET, for example, is very low compared to the non-controls in patients with Parkinson's disease. So the thing is that if you use F-DOPA, it quantifies the activity of DDC, which converts the levodopa to dopamine, and this DDC activity is actually upregulated as a compensatory mechanism, right? Because in the remaining cells. So because you want to maximize the capacity of synthesizing the dopamine, because there are not so many dopaminergic cells are left. So if you use F-DOPA, actually you kind of underestimate the disease progression. And if you use dopamine transporter imaging like FDG-PET, dopamine transporters are downregulated as a compensatory mechanism, right? Because if you there is not much of dopamine transporter, then the time that the dopamine will spend in the synapse is going to be increased because there is no clearing out. And so it's the compensatory downregulation. And so if you use a FDG-PET to monitor, to quantify the dopaminergic cell degeneration, it actually overestimates the level of degeneration. And tetrabenazine is actually is not affected by this type of compensatory mechanism. So if you use tetrabenazine as a biomarker for Parkinson's disease, it's the most accurate measure for dopaminergic cell degeneration. However, what would be then the best biomarker for early detection of Parkinson's disease in this case? If you want to detect the Parkinson's disease, if you want to give us some accurate early diagnosis, what radiotracer should you use?
The last one,
The dopamine transporter.
tetrabenazine.
Well, tetrabenazine is although tetrabenazine gives you accurate measure of a dopaminergic cell degeneration, but actually if you use FDG-PET, for example, it overestimates the dopaminergic cell degeneration, which means that the difference from the normal control is even greater. So for the early detection of Parkinson's disease, actually FDG-PET is the most widely used biomarker for Parkinson's disease diagnosis. So it depends on what is your question. You can use different tracers. For example, if you want to understand the compensatory mechanism of dopamine synthesis, then you have to use F-DOPA to monitor the changes of whatever you are doing, some treatment or whatever. Or if you want to just monitor the natural disease progression over a long time, then you may want to use tetrabenazine. Or if you use it for diagnosis, then FDG-PET would be the best bet. And if you, in the postsynaptic side now, if you inject D2 repropride, D2-D3 receptor antagonist, it binds to the D2-D3 receptor in here. And so actually in patients with Parkinson's disease, it's the repropride binding potential is increased because presynaptic cells, dopaminergic cells that project to the striatum are degenerated, so there is less dopamine available, but the postsynaptic cells that receive this dopamine are intact. So when there is no dopamine influx going into the striatum, but the receptor expression is still high, or sometimes it's even upregulated, so that there is more room for repropride to bind. So repropride binding potential is actually increased in the patient with Parkinson's disease. And if you use FLD457, which is basically same to recopride but has higher affinity, so that you can also monitor the other regions that are not very abundant with the dopamine receptors, because dopamine receptors are very abundant in the striatum. This is the striatum. And so if you use a recopride, the signal is very weak in the extrastriatal regions. But if you use a FLP47, you can image the extrastriatal dopamine regions, extrastriatal dopamine system, because it has a higher affinity. But in the stratum, on the other hand, it's too dense, so it's too much signal, and it doesn't equilibrate during the 90 minutes of scan time. So the estimation of the binding potential in the stratum is not accurate if you use FME. So it depends on what is your question. You can select different radiotracers to answer your questions. So now I'm going to talk about what you can do using this type of technique. I'm going to just give some examples. So this is another synapse, and this is a dopamine. Dopamine is released in the synapse, and these red dots is a recopride. So in control condition, let's say there is a baseline level of dopamine in the synapse. There are 1, 2, 3, 4, 5, 6 dopamine and 3 recopride. Recopride now is compete with the dopamine to bind to the dopamine receptors. So now recopride binds to 2 of the dopamine receptors. In the active condition, for example, if you give patients some amphetamine or levodopa, something that releases dopamine, then there is going to be more dopamine released in the synapse. And so there's more competition. Now recopride binds only one of the dopamine receptors because there's more competition. And so recopride binding potential is decreased. So this model suggests that the recopride binding potential is inversely proportional to the synaptic dopamine concentration, which means that if you compare these two conditions, you can estimate how much dopamine is actually released in the stratum that you're looking. So this is what we did. So this is a healthy young subject. This subject was performing some variant of the Wisconsin Karsten test, which is we named Montreal Karsten test because I was in Montreal. And this task is basically involves a lot of executive function. It's high level cognitive performance. And compared to the control condition, which is basically matched motor movement during this task, there was a decreased recopride binding potential in the bilateral caudate nucleus and putamen, which is in line with a lot of executive function brain imaging literature. So when there is a decreased recopride binding potential, that means there is an increased dopamine release. And performing this high demanding cognitive task increase the dopamine release in the stratum. And that may explain why does patient with Parkinson's disease have impaired performance in this type of executive function task. Because patient with Parkinson's disease has dopaminergic cells are degenerated, so they cannot really release a lot of dopamine. And this task, performing this task, requires you to release dopamine in the stratum to perform better. And then Parkinson's disease patients cannot do it, so they are basically impaired. That's our hypothesis. And for example, if you inhibit the left dorsolateral prefrontal cortex with the transcranial magnetic stimulation, which will disrupt the function of the dorsolateral prefrontal cortex, and then it's going to impair the subject's performance of this parasympathetic task. The subject is going to make more errors, and then it's going to also disrupt this task-induced dopamine release. And so it's actually going to increase the recopride binding potential of the bilateral caudate nucleus compared to the vertex stimulation, which means that the left dorsolateral prefrontal cortex was necessary the actively healthy left dorsolateral prefrontal cortex was necessary to release dopamine in the caudate nucleus when the subject was performing this task. And on the other hand, the right dorsolateral prefrontal cortex stimulation didn't do anything. It didn't make the subject make more errors, and it didn't change the required binding potential. So this study also suggests that the left dorsolateral prefrontal cortex is important, is necessary to perform this type of executive function task, and it works with the caudate nucleus together as a network, which may explain why both Parkinson's patients are impaired in this type of carcinogen task. But also another group of patients who are impaired in this type of carcinogen task is the patient who has lesions in the frontal lobe, especially in the left dorsolateral. If you have lesions for whatever reason, it's tumor, it could be some epileptic surgery, then you are impaired in this type of carcinogen task. And so it kind of nicely fit with this understanding of the diseases. And now if you use FLB457, same thing, performing this type of executive function task, there was decreased FLB binding in the anterior cingulate. And so this anterior cingulate is traditionally known to be involved with some conflict monitoring, and performing this multiple task also you have to have some monitor the conflict in this task performance. So that's why we think that there was a dopamine release in this region. And another interesting finding was that when we scanned to some more older control subjects, healthy older subjects, there was a significant correlation between FLB binding potential and the MoCA score, which is a Montreal cognitive assessment, which is the level of cognitive integrity. And so, for example, if you have dementia, you have a very low score in this region, and 24, 25, this is basically mild cognitive impairment. And so there was a nice correlation between FLB binding potential and MoCA score in the bilateral dorsolateral prefrontal cortex and the anterior cingulate, which is also this anterior cingulate, dorsolateral prefrontal cortex. They are basically the core regions of executive function, and we demonstrate that there was some correlation between FLB binding. So dopaminergic system in this region is also quite important in this type of high-level cognitive function. But this type of correlation was not observed in the PD patients, and possibly due to this overall reduction of FLB binding in PD patient, because as I said, record prime, if you use a record prime binding potential was increased in the PD patients because the dopaminergic cells are degenerated, and there's an overall compensatory upregulation of the D2 receptors in the striatum. But if you use FLB, you can scan the extracellular regions, and FLB binding potential is actually decreased in the PD patients. And we believe that that's because, but post-mortem studies suggest that the D2 receptor density is not decreased. So it may mean that in the baseline condition, these patients release more dopamine in the baseline as a compensatory mechanism, so that there's no competition for the FLB to bind to dopamine receptors, so that FLB binding is decreased. And so we also looked at the interaction effect of a group versus task, and there was some significant effect in the ventrolateral prefrontal cortex and orbital frontal cortex. So we looked at the simple effect of a task within each group. So in the control group, the healthy controls, there was a decreased FLB binding in orbital frontal cortex and some limbic regions when they performed this Montreal cluster task compared to the control task. But that was not happening in the PD patients. And instead, there was actually increased FLB binding potential in the anterior cingulate, ventrolateral prefrontal, and these regions in the PD patients during the performance of the Montreal cluster task. So, the orbital frontal cortex is involved with the reversal learning, and our Montreal clustering task basically has this component as well. So it kind of makes sense that the orbitofrontal cortex is involved with this Montreal clustering task. And this is our hypothesis about what actually happened. So this is the orbitofrontal cortex, dopamine receptors. This is FLB. This is dopamine, and this is dopaminergic cells that is projecting from ventral tegmental area to frontal cortex. So when you perform some kind of this Montreal clustering task, it releases more dopamine in here in orbitofrontal cortex. So it displaces the FLB, so that FLB binding potential is decreased. But in the PD patients, the FLB binding potential was already reduced, possibly due to this compensatory upregulation of dopamine concentration in the baseline, so that performing this test do not further, maybe further increase, but it just doesn't further decrease the FLB binding, in terms of, and maybe there's some kind of a ceiling effect. So, but. And then we can also look at what happened in the ventrolateral peripheral cortex. Ventrolateral peripheral cortex is involved with the shifting of the Montreal clustering task. But somehow, in the fMRI study previously, there was some increased activation in the ventrolateral peripheral cortex during this Montreal clustering task, but FLB binding was not changed in the normal control subjects. So we believe that maybe it's not although ventrolateral peripheral cortex is involved in this task, but maybe it's not just dopaminergic, maybe it's something else. But in the PD patients, in the baseline, because there is a compensatory upregulation of dopamine concentration in the ventrolateral peripheral cortex, the FLB binding is already reduced in the baseline. And somehow performing this Montreal clustering task increased FLB binding. When there is a decreased FLB binding, it's kind of easy to understand during the active condition. When there is a decreased FLB binding, because there is more dopamine released. But what does it mean by increased FLB binding? It's so it was kind of difficult to understand. So one possible explanation is that maybe performing this high-level cognitive task somehow reduce dopamine release. But I don't know, I mean, intuitively it doesn't make any sense. Why this is a more demanding task, you are putting more effort, there should be more dopamine that is involved in this Montreal clustering task. So another hypothesis is that maybe the receptor, dopamine D2 receptors are somehow acutely upregulated and they're acutely expressed in this region. Then it may actually explain that FLB binding, explain the reason for the FLB binding increase. And in fact, if you the increased FLB binding in these patients are actually correlated with the LOHA score. So which means that those patients who are impaired in terms of cognitive performance, they increase even more receptor expression as a compensatory mechanism. So then the next question is it really possible to acutely increase the dopamine D2 receptor expression in those, this FLB scans takes about 90 minutes. Is it really possible to upregulate the D2 receptor in that short period of time? Well, at least in the animal models of Parkinson's disease, if you give levodopa, it increases D2 receptor density in about 1.5 hours. And in the PD patients also, if you give levodopa, it increased the recopride binding potential in the cardiac disease. So we are not alone, we are not the only group that see this increase of recopride or FLB binding potential. And the C4 mRNA expression is increased by acute levodopa challenge. And that is not just limited to the stratum where the recopride was used, but it's also happening in the extracerebral regions, including prefrontal cortex and anterior cingulate. And finally, GLO previously showed that this recycling of these internalized receptors can be happening in 30 to 60 minutes, at least in vitro, not in vivo, but still, it suggests that mechanistically it is possible to regulate D2D3 receptor in that short period of time when it is needed. So, in the first half of the talk, I talked about the dopamine imaging, how it can be used, and now I'm going to talk about brain pattern analysis. So, FDG is basically F18 labeled deoxyglucose. It's basically a radioactive sugar, and so this is very useful. And FDG is actually the most widely used PET tracer because of its utility in the oncology. Because cancer cells takes a lot of glucose. So if you inject FDG, then the cancer cells light up. But it can be also used in the neurology or psychiatry. For example, patient with Alzheimer's disease has a hypometabolism, increased glucose uptake in the parietal and also in the temporal regions. And frontotemporal dementia patients also have some hypometabolism, of course, in the frontal lobe and the temporal regions, as the name stands. So this could be used for diagnosis of these disorders, but for Parkinson's disease, it's not this clear. And sometimes it is, even with the trained neuroradiologist, you cannot really, just looking at the FDG PET scan, you cannot really say this is Parkinson's disease or not. So, so we took another approach using the multivariate analysis to derive a pattern that we cannot really see with the bare eyes. And so this is how we do principal component analysis. So let's say each dot represents each subject. And this is basically the multidimensional vector. It's a vectorized volume of FDG PET scans. And there is a PD patients, and this is the controls. And what the PCA does is that it tries to find the eigenvector that, it tries to find a multidimensional vector that explains the majority of the covariance of this pooled group of PD patients and normal controls. And then it happens that this one of these eigenvectors differentiate the PD patients from normal controls. Well, it could be something else, also Alzheimer's, but we are talking about Parkinson's disease. So if we differentiate the PD patient from normal controls, we can name it as a disease-related FDG pattern. And the advantage of this technique is that we can quantify the scalar of, quantify the degree of this PDRP expression in each individual subject. So it gives you one number, how much this patient expressed this PDRP. And another advantage of this technique is that you can quantify this PDRP expression in the independent subject who was not used in this pattern derivation. So it can be prospectively used. So this is a pattern that we found with this PCA, Parkinson's disease-related pattern. It has some hypermetabolism in these regions and hypometabolism in these regions. It doesn't matter whether you use FDG or perfusion PET or perfusion MRI, as long as it reflects some neuronal activity, it kind of gives you a very similar pattern that characterizes this special pattern that characterizes Parkinson's disease. And the PDRP expression was significantly higher in the PD patients compared to normal controls. And these are basically the subjects who were used to derive this pattern. And the differentiation between PD patients and normal controls was also true in those subjects who were not included in the pattern derivation. So this is a training set, in this testing set, and you can still see nice differentiation between PD patient from normal controls. So this could be a useful diagnostic tool. And the PDRP expression was correlated with the patient's motor symptom severity, so it is clinically relevant. And anti-Parkinsonian therapies such as levodopa or subthalamic nucleus deep brain stimulation, subthalamic nucleus lesion, they all decrease PDRP expression. So it responds to the anti-Parkinsonian therapy. And the most interesting recent finding was that these are the patients who have REM sleep behavior disorder, not the Parkinson's disease yet. But if you have REM sleep behavior disorder, you are at a higher risk of developing Parkinson's disease. And this Hyun et al. Followed up these REM sleep behavior disorder patients for about 4.5 years. And it turns out that those patients who have high PDRP expression eventually converted to Parkinson's disease or dementia with Lewy body in those 4.5 years of follow-up period. So this could be really useful early detection tool of the Parkinson's disease even before the patient express the motor symptoms. And there is also another disease-related pattern. This is Parkinson's disease-related pattern, PDRP. This is MSA-related pattern. MSA is a multiple system atrophy, which is symptomatically is very similar to Parkinson's disease, but pathophysiologically is very different. And the progressive nuclear palsy is also another typical Parkinsonian syndrome. The symptom could be very similar to Parkinson's disease, but the prognosis and the treatment could be very different. And so this is PSP, MSA, PD, and using this pattern, and these are all derived, it can be calculated with FDG-PET scan. So if you take FDG-PET scan for each individual subject, and then you can estimate the PDRP expression, MSA expression, MSARP expression, and PSPRP expression, and you do the logistic regression, then you can classify each patient belongs to which disease group. And then all the differential diagnosis was possible even before the clinical follow-up diagnosis was possible, because these patients, MSA, PSP, PD, they kind of, in the initial stage, it is sometimes very difficult to tell whether you have a Parkinson's disease or MSA or PSP because their symptoms are very similar. But as you go on, maybe 2 or 3 years clinical follow-up, now you can really give the patient some clear diagnosis. Sometimes it happens, and this Hyun et al. Basically followed up. I think it was 130 something patients who had undeterministic diagnosis in the baseline, and they got all FDG-PET scans, and they compared those brain imaging based diagnosis with clinical follow-up diagnosis. Some of them are actually post-mortem confirmed, and the sensitivity and specificity was over 90%. So using this technique, you could give some early diagnosis even before clinical diagnosis is available. And this is important because if you have MSA and PSP, the prognosis is very poor, and sometimes it's not really some news that you want to hear because the life expectancy is about like 5 or 7 years if you have MSA or PSP, but if you have Parkinson's disease, you can live like 20 years. So sometimes it's kind of hard to, maybe some patient may not want to know, but at least there's a tool to provide that kind of information. And PDRP has been replicated in 4 different PET centers in the States, Netherlands, China, and India. And the topographically, they were very similar. So that it doesn't matter what kind of scanners you use or which ethnic group, but if you have Parkinson's disease and FDG-PET, you can more or less generate this PDRP and use it as a biomarker. So as I said, the FPCIT is basically the most widely used brain imaging-based biomarker for Parkinson's disease because thanks to its high sensitivity, but it doesn't have much specificity. For example, this is a FPCIT uptake in the normal controls. This is non-limited Parkinson's disease with dementia. dementia with Lewy body. They are all basically the same spectrum of Lewy body disorder. And this is MSAP, which is MSA Parkinsonism, which we often confuse with the Parkinson disease. And this is MSAC, it's MSA cerebral ataxia, which is symptomatically quite different, but it's there just because for the comparison with MSAP. Then PSP is progressive supranuclear palsy, it's also Parkinsonism. And CBS is cortical basal syndrome. So as you can see, if you look at the CIT uptake in the putamen, you cannot really differentiate the Parkinson disease from MSAP or PSP. They all have a degenerate dopaminergic system. And if you, this is a caudate nucleus, about the same story. And then this is a ratio between putamen and caudate in PCIT uptake. Parkinson's disease, MSAP are not that different, but PSP is a little bit higher, which means that Parkinson's disease or MSAP has even more degeneration in the putamen compared to caudate. Caudate is relatively spared, although it's significantly different from the controls. But PSP does not have that gradient. So if you use this ratio between putamen and caudate nucleus, you can maybe differentiate the PSP patient from other idiopathic Parkinson's disease, but still you cannot differentiate MSAP and Parkinson's disease. If you use a PDRP, the Parkinson's disease, non-demented Parkinson's disease, PD, dementia, dementia with Lewy body, they all have very high PDRP score. MSAP has a very low score, so you can differentiate that. And if you use MSARP, MSA patients has high score. PSP also has a CBS patient also has a high score, but there is also PSP RP. PSP patients show very high score of PSP RP, and this is a CBS RP score, and CBS patients has a very high score. So the thing is that these scores are calculated from one FDG-PET scans. So combining these score and do the logistic regression, you can also provide accurate diagnosis with a over 90% of sensitivity and specificity. And interesting finding here was that the FDCIT binding, FDCIT uptake in the putamen in those Lewy body disorder patients, which is Parkinson's disease and dementia with Lewy bodies, was correlated with PDRP score, which is not too surprising, but that was not the case in the MSA patients or PSP patients. So, which may explain why levodopa doesn't really help the MSAP patients or the PSP patients, but PD patients, the Parkinson's disease respond well to levodopa. And as you can see here, for example, MSAP patients, the FDCIT uptake was correlated, trend level correlated with disease duration, while the MSARP score was significantly correlated with the UPDRS, which is a motor symptom severity. And so I think this MSARP provide more directly related with the symptom expression, and that's why if you treat the dopaminergic system, it doesn't address the symptom because the dopamine degeneration is not directly related with symptom expression. And it's the same story with the PSP. So another issue with this technique is that, so this is a Parkinson's disease related pattern. So there is this hypometabolism in these regions, but it doesn't, having this pattern expression doesn't tell you how each regions are connected to each other, how they are communicating, and although we call it as a network. So in order to understand this, we did a graph theory analysis. So this is just a hypothetical graph with some core and periphery structure. These are the nodes and these are the edges. So this is basically the same technique that we use for global page rank, understanding the social network, who's the hub of the network, something like that. And so, for example, if you start your random walk from here, and then in the next iteration, you are bound to end up here. And in the next iteration, you have a 1/8 chance of ending up here, 1/8 chance that you may end up here, and etc. And in the next iteration, it's more likely that you end up here, and here, or here. And if you just go on, it's going to equilibrate. So if a sufficient number of iterations is passed, then there is 8.84% chance that you may end up here, and 7.33% chance that you may end up here, and 2.21% chance that you may end up here. So the one thing that we should note here is that these guys have 8 connections, right? 8 degrees. And this guy has only 4 connections. But still, this guy has even higher probability, which we call Eidelberg centrality. So, as everybody knows, it doesn't matter how many people you know. It matters who you know. Right? So, the central hub is basically the controller of this network. And we did the same analysis with the brain imaging data. And we did this graph theory analysis in PD patients with non-controlled group separately. And it turns out that this algorithmic centrality was correlated with the absolute region rates of the Parkinson disease-related pattern in PD patients. And which means that those hypermetabolic or hypometabolic regions that was identified from our previous critical component analysis was actually the hub of this brain network. And that was basically replicated in 2 more cohort for PD patients. This is only PD patients, lay PD patients, they all suggest the same thing, but not in the normal controls. So this hypometabolic or hypermetabolic regions that is identified by this PCA analysis is the hub of the brain network in the PD patients only. So, but the problem of this technique is that it doesn't really, it doesn't really give you an edge that can differentiate this regional hub and this central hub. Because although regional hub has high eigenvalue centrality, but comparing these two, it's not that there is no clear threshold that you can use to differentiate in the real graph, although in the hypothetical graph it's okay. So we did this sensitivity analysis. So in order to do this, we basically sum the eigenvector centrality of this subgraph of the hub region. For example, it's 0.0884 plus 4 times of 0.0733 is a 0.3814. So this is the sum of eigenvector centrality of this subgraph. And then if you increase the functional connectivity of this single node here, then recalculate the eigenvector centrality of the remaining graph, then these nodes will have increased eigenvector centrality because this node has increased connectivity. So it's attracting the information now. And so, but the other nodes that are distant from this this node that has been manipulated, they will have decreased eigenvector centrality. So overall, if you sum the eigenvector centrality of this subgraph, the new sum eigenvector centrality of the subgraph is decreased. And if you do that, do the same thing with this regional hub, at the end, you are going to increase the eigenvector centrality of here, and slightly a little bit here, but decreasing the eigenvector centrality here and here and here, so that at the end it's going to balance out, and there's not much of change. But if you increase the functional connectivity of this central hub, then it's going to increase the eigenvector centrality of all of these hub regions, so that it's going to increase the eigenvector centrality. So using this technique can be, and then you just do this for every region, so, and then you can identify those central hub, the real hub of this graph. And we did that, and with the PET data of these patients, and then the visualized using graph-based software to construct the graph based on the hierarchy of the importance of this sensitivity analysis, and it basically put those caudate, pallidum, putamen, and thalamus in the central hub regions, and the other hypometabolic regions and other regions are in the surrounding. So, which means that using this graph theory sensitivity analysis, we could identify the core of the subgraph of that is relevant to the Parkinson's disease-related pattern. And in fact, for example, if you give deep brain stimulation, which is in the patient with Parkinson's, deep brain stimulation is a kind of very sharp electrode, and then you just insert it in the patient brain in the regions that we identify here, pallidum or thalamus, basically it ameliorates the symptoms. So this study suggests that disrupting those regions that has been identified as a central hub in the graph theory sensitivity analysis may disrupt the overall formation of this PDRP network and then address the symptoms. And there is another brain network that is related to Parkinson's disease. This is Parkinson's disease cognitive pattern. Basically, this is a second principal component that is derived from Parkinson's disease patients' FDG-PET scans, and PDCP expression is correlated with global fluency and executive function tasks, etc. And then we do calculate the centrality of this PDCP-related pattern by orthogonalizing the FDG-PET scans to the first principal component. And so it kind of gives you also another graph that is relevant to the PDCP network formation. And then this analysis gave you right superior frontal gyrus and right middle frontal gyrus as a central hub of this PDCP network. And basically, so we hypothesized that maybe if we inhibit one of these central hub with a transcranial magnetic stimulation, it may actually ameliorate the cognitive deficit in patients with Parkinson's disease, because levodopa doesn't really help the cognitive dysfunction in these patients. So I don't have much time, so I'm going to briefly go over. This is placebo effect study. Placebo, if you give a placebo pills or sham transcranial magnetic stimulation, it also decrease rapid light binding potential, which means that if you give placebo, the patient release dopamine in the striatum so that they feel better and they move better. And we looked at the patient who actually benefited from the sham surgery, and this was not just the acute placebo effect, that the effect lasted like 6 months. So we wanted to know what's going on in these patients, because all they got is just a ball, and then that's it, there's nothing going on. Just some saline, but that doesn't help. And so what happened in this patient, first we characterized this using another principal component analysis, ordinal canonical variate analysis. We characterized this pattern that has some hypermetabolism in the subject anterior cingulate, cerebellum, etc. And as you can see, and then we named it as a sham surgery effective related pattern, SSRP. As you can see, the patient who benefited from this sham surgery has monotonically increased SSRP expression, and that was also the case in the patients who were not involved in this pattern derivation. So this is training set, this is testing set, it's uniformly increased. But that was not happening in the patient who did not benefit from the sham surgery. So those non-responders had slightly decreased, but not significant change. And we also looked at what happened in the patient who had open label levodopa. levodopa should help the patient symptoms. So UPDRS motor score was decreased, but SSRP expression was not changed. So which means that these SSRP, increased SSRP expression is not just the epiphenomenon of improved motor symptom, because if it was the case, then levodopa should also increase SSRP expression, but it didn't. So this must be something really directly involved with the real motor symptom benefit in these patients. And this UPDRS motor score improvement was correlated with SSRP expression increases, and also it was also related with the BDI, which is back depression inventory, which is a mood scale. So this SSRP is not just improving the motor symptom, but a little bit of a mood too. So it's and those anatomical structures of this SSRP is actually quite limited. It's related with the emotions, so it kind of makes sense that it also is related with the improvement. And also we looked at what happened in the patient who actually received the real gene therapy, and and these are basically the patients who got benefit from the gene therapy. This is SSRP expression in the gene therapy group. There was a slight increase, but significantly less than the patient who benefited from the sham surgery, which suggests that these patients who received the gene therapy, their improvement is not just the placebo effect. There must be something else going on, because they didn't fully activate the sham surgery effect related pattern. So we also looked at what happened in the patients who were unblinded after a 6-month trial. So after unblinding, so they were told that they received the sham surgery now, and except this patient, the majority of the patient SSRP expression goes down. So SSRP expression is reversible by unblinding that you had actually sham surgery. But that was significantly different from what happened in the patient who actually received the real gene therapy. Those patients, except one patient, all went up. Because when you're told, oh, you have actually the real gene therapy, now the sham effect is toxic. And some patients actually were kept blinded over 12 months, and except one patient, they all continue to go up. So the placebo effect is still there. And also the same thing happened in patients who received real gene therapy who were kept blinded. And I'm going to skip this. So in the first half of the talk, I talked about there are many types of radiotracers that you can use to answer different questions. And also I talked about whole brain pattern analysis and how it can be used as a biomarker for different types, the motor symptom, cognitive deficits, placebo effect, and dyskinesia, and how it can help us to develop a new novel treatment with graph theory and transcranial stimulation. And that's it. This is the question.
All right, got time for just maybe a couple of quick questions if anybody has any. All right, I'll ask one. Yeah, so I was curious actually, because whenever you think, or whenever I thought of dopaminergic systems, I think more basal ganglia. So I was surprised in the first half of the talk how much dopaminergic neurotransmission happens in the dorsolateral prefrontal cortex, etc. Do you know what the ratio, and I think maybe one of your last slides on the first part of the talk may have touched on that, but I didn't quite get that. What the ratio is of dopaminergic receptors in the cortex versus the basal ganglia?
I vaguely remember, but I think it's, but don't take it as accurate, but I think it's about 1/20.
Okay, it is a lot lower.
Yeah, a lot lower. So if you use a record-pride, then you can't really image those regions that has scarce dopaminergic receptors. Although there are some people who still publish it with that, but
okay,
it's not reliable.
Okay, okay, so the sensitivity is 20 times lower. Okay, gotcha. Any others?
Regarding DOPA scan, can we consider DOPA scan as a golden standard diagnosis procedure for Parkinson's disease or MR? Or so if somebody like has suspicion he has Parkinson's, what to go to, DOPA scan or DAT scan? Or
Well, the current gold standard so far, at least here in Winnipeg, is clinical follow-up. And so the PET scan is not actually covered by insurance in many countries, but it is covered in some of the European countries, and some countries they use off-label to give a better diagnosis. But at first, FDOPA was widely used because it's first developed. It's actually developed even earlier than FDG. But the FPCIT is now most widely used, or beta CIT, SPECT scan, because it's, as I said, FDOPA is kind of, if you use FDOPA, it underestimates the severity of the dopamine cell degeneration. So if you use that, then the difference from normal controls to PD patient is not that great. But if you use a dopamine transporter using PCIT, it's even greater than actual dopamine cell degeneration. So in terms of usability, it's more useful, and it is used in a clinic in a daily basis in some countries, but not here.
Any others? All right, well, thank you again.